So, very good morning to everybody. I think for the past 2.5 hours on insulin, we have enough made insulinization of your brain, no? And this could be the last topic for the insulin today. And my topic is in hospital management. First of all, thank Dr. Vijay sir for giving me this opportunity. And this is the management. Yes, 1 second. In hospital management, especially management of diabetes in ICU care. I am Dr. Ravindranath from Trichy. So my talk will be going through these three topics: burden of hyperglycemia in critical care, and the principles of management and recommendations from guidelines. And the third thing is a transition of the IV insulin to subcutaneous mode of insulin therapy. So coming to the classification of hyperglycemia in a hospitalist patient, what are the patients that you are going to see, the presentation of patients in our hospitals? So hyperglycemia in hospital patients may present in all these three forms. One is the previously existing type 2 diabetic patient may come to your hospital for admission. So diabetes diagnosed prior to the admission. And second thing is previously undiagnosed diabetes. Patient do not know that he has got diabetes, but he has come to the hospital with a HbA1c of more than 6.5, fasting more than 126, more than 200 of random blood sugar or the postprandial. If he comes with, so newly detected diabetic at the time of admission. This is a second sector of patient that we see in our practice. And the third thing, patient is not a diabetic patient, but he has got a hyperglycemia because of the stress factors. And here you can see the fasting sugar will be high, more than 126, postprandial will be high, but you even see the HbA1c, it will be 5.7, less than 5.7. So these are the three categories that we come across the patients in our day-to-day settings. So by definition, what is hyperglycemia and hyperglycemia in a hospitalized patient? Any patient with hyperglycemia in the hospital has been defined as any blood glucose that is more than 140 here. Very strict control of blood sugar parameters. So stress hyperglycemia, elevations as I told you, A1C should be less than 6.5. If the A1C is more than 6.5, suggests you have the prior history of diabetes. And we brand it as a hyperglycemia when the sugar levels goes below 70. And severe hyperglycemia when the blood sugar goes below 40. So this is the definition and details of the hyperglycemic status. This hyperglycemia is associated with the increased mortality in the critical care setting. As you see this graph, from 100 to 200 blood sugar level, there is a twofold increase in the mortality. And from 200 to 300, there is a threefold. And more than 300 is almost fourfold of increase of the cardiovascular mortality is seen with this study. And mortality risk in highest in the ICU care. You see the normal patients, total patient, non-ICU patients, and the ICU patients. The patients present here with a newly detected hyperglycemia has got the highest mortality in the ICU setting than the diabetic patients. So hyperglycemia and poor outcomes following myocardial infarction. This was a study that was done whether this type 2 diabetes or the non-diabetic patient or the stress hyperglycemia, they develop complications. That's immaterial because the admission time, what the blood sugar is there, that determines the outcome of the patient. Here you can see patient categories based on the admission blood glucose level. So admission glucose levels and diabetes were the independent predictors of the mortality, whereas infarction size was not. So infarction size doesn't matter, but the presenting amount of hyperglycemia, that accounts a lot. This is the diagammy study where they have done two arms. One is the conventional and second is the very strict control of blood sugar level, where they have seen in all subjects almost there was a risk reduction of almost 25% in all subjects. And low risk and not previously on insulin therapy, they have got even the reduction in the mortality rate. So coming to the principles of management and recommendations from the guidelines. Here you can see the other study, intensive glycemic control. One arm was given a strict control of almost, you can see 80 to 110, another one was 180 to 200, whereas you can see the outcome drastically when by reduction of the blood sugar level, you get a better benefits here. So for every 20 milligram of rise in the blood sugar, there is almost 30% increased risk of death. Mortality is increased by almost 30% if a 20 milligram of blood sugar is rising. So this is the thing that they have found out from this study. So this is the association between the hyperglycemia and increased mortality in critical care setting. You can see every almost 20 milligram of rise, they got a increased mortality rate in this time. So tight glycemic control in ICU and CCU. this was an observational study where they have shown benefits of reduced risk of mortality, infections, and atrial fibrillation with a tight glycemic control in intensive care setting. So that now we know that hyperglycemia is associated with high mortality. Yes. But is intensive glucose lowering associated with improved outcome? This is the question that $1 question that we have come across. So with this, we are going into a small study, nice sugar study, where have then patients selected, were given two types of arms. One is the intensive glycemic control with the blood sugar, they are maintaining between 81 to 108. In another arm, conventional group, where they have maintained blood sugar less than 180. So they have seen the outcome, what happens if the blood sugars are kept below 180 or even a very strict control of between 81 to 108. This was done in the nice sugar study, where they have found out the significant higher death rate, 14%, and higher incidence of severe hypoglycemia in intensive glycemic control. So when you attain the glycemic parameters in a very low level, you tend to develop a hypoglycemic episode, because we will not be able to predict the amount of insulin the patient requires, amount of insulin resistance, everything we cannot able to assess, because there is no test available at present to assess the insulin resistance status, what is the beta cell preserve is there, nothing we can do. But just based on the numerical values, we are going to treat the patient. So whether this intensive glucose control gives any benefit over the patient, this was done in the nice sugar study. Here they have done ADA consensus statement, and inpatient glycemic control recommends a blood sugar target of between 140 to 180 once IV insulin is started. So this is what they have done here, and what is the outcome here they have done here. So they have got a highest mortality rate and hypoglycemic episode with the nice sugar study. So the right target is keeping the blood sugar less than 180 is advisable, but not less than 108 milligram is the right target. This one has to understand. It should be less than 180 and it should not go below 180 also. So this is the Vijayakumar study they have done with a severe septic patient, where they have done the intensive arm and the conventional arm also. Blood sugar target was given as two arms. One is the 180 to 110 and another arm was 180 to 200. What they have found out? The trial was stopped early for safety reason because of the increased risk of hyperglycemia. So this is the danger that we encounter by giving a strict blood sugar control. You are going to encounter a lot of hyperglycemic episodes, because hyperglycemia is more deleterious than hyperglycemia, because it also it triggers all the inflammatory pathways, it triggers the cytokines, everything. So all these things are triggered with the hyperglycemic event. So when the patient develops hypoglycemia, they tend to go for the cardiovascular outcome. So this is also one trial, glucocontrol trial they have done with the patient. The risk of death was not increased by hyperglycemia here, they have said, and there was no apparent benefits of tight glycemic control from this glucocontrol trial. So whether the tight glycemic control in critically ill adults, this is the meta-analysis they have done. Intensive insulin therapy in critically ill patients, no overall mortality benefit. They have analyzed so many trials, they have analyzed and given a meta-analysis. No overall mortality benefit was seen, and significantly increased the risk of hypoglycemia. Only thing, they have got encountered with a lot of hypoglycemia to the patient, and may be beneficial to patients admitted to a surgical ICU. Because on the study that they have done previously with the thing they have done in surgical ICU, their patients were able to tolerate the hyperglycemic episode, and they are able to achieve the glycemic load with a lower level, and it yielded some benefit, but not in the medical ICU. The severe hypoglycemia in critically ill patients associated with the increased risk of mortality. So severe hypoglycemia less than 40 milligram was associated with a higher mortality rate. So all these recent studies suggest that perhaps these targets are very too strict on Vandenberg study, Weissap study, glucocontrol, nice sugar study, what I have told. All these studies, they got a frequency of hypoglycemia of less than 40. So tight control, what is low? How much we have to achieve? So these are the parameters they have given from the AACE and ADA guidelines. The glycemic targets for the critically ill patients. Starting threshold of no higher than 180 milligram. Once IV is started, the glucose level should be maintained between 140 to 180, and lower glucose total 140 to 110 to 140 may be appropriate in selected patients, and targets of less than 110 or more than 180 are not recommended. So this is the value. Above 180, not recommended. Below 110, not recommended. But recommended range is 140 to 8, and reasonably acceptable range is 110 to 140, we can able to accept the range. So this is the one they have given as a targeted level for achieving the glycemic target in ICU. The principles of hyperglycemic management here, the goal of the insulin therapy is to reach the acceptable glucose level within a short time. We want to have a quicker action of glycemic reduction should be there in the ICU setting. That's the one parameter that we have to bear it always in the mind. And once admitted to the ICU, patients with hyperglycemia should be managed only with IV insulin and none else. In ICU patient, no other drug has got any role in ICU setting. Only insulin, insulin and insulin, nothing else. So most treatment algorithms recommend discontinuation of oral diabetic agents and initiation of insulin analogs. And insulin is the preferred agent for the glycemic control in hospitalized patients. So there are some challenges that we encounter: severe or rapidly challenging insulin requirements, impaired perfusion of subcutaneous sites, and requirement of the pressure support. We need to have some sort of pressures for all the ICU patients, and that hinders the treatment modalities and the insulin requirement also. And the use of the parenteral nutrition. As I told you, in this morning session also we had a discussion. The total parenteral nutrition, we have to give insulin for the therapy. Even the patients are non-diabetic patient and you are going to give TPN, definitely the patients will require insulin therapy for the demo. So it's the non-diabetic use of insulin is one of the things that I told you in the morning. So intravenous route for insulin administration surpasses the subcutaneous route, and rapidity of the onset is one of the main things that we have with the short-acting analogs. And overall ability to achieve the glycemic control is with insulin only. The components of insulin therapy, concentrations should be standardized throughout the hospital, and acceptable blood glucose level should be reached, and potassium should be monitored and given if it's necessary, and clearly communicates the instructions to the nurses responsible to treating. So we have to give the instruction to the nurses about this therapy. And if you see, there are so many protocols comes. Even nowadays, remember one single protocol is nowadays difficult as the age advances for us. There are so many protocols that come to the market, but how are you going to? These are the protocols: Portland, Levon, YAL protocol. So many protocols has come. And the exact protocol is probably less important, whichever may be the thing. What is important is the presence in an institution and adaptation to the individual hospital needs. So what type of hospital that you have got, what type of paramedical staff that you got, how much training they have given to your nurses, that is more important to adapt to any type of protocol. So you have to tailor your own type of treatment according to the thing that you have got in the hospital, what facilities you have got in the hospitals. So this is the updated YAL insulin infusion protocol. Here, insulin infusion almost mix 1 unit of regular human insulin per 1 ml of normal saline, administered via the insulin pump with an increment of 0.5 units per hour. So target of blood sugar level should be 120 to 160 here, and use glucometer to monitor the blood sugar level, and once it is stabilized, monitor every 2 hours. And the bolus and initial infusion, how we are going to choose the dose of the insulin, divide that initial blood glucose level by 100. Whatever the patient level, when the patient comes, just assess the blood sugar level and just divide it by 100 and give the nearest value. So how are you going to do? For an example, if the patient's blood sugar is 325, divided by 100, what it gives, it only 3.25 units. And what you have to do, the IV bolus insulin should be 3.5, and the insulin infusion rate should be 3.5 units per hour. So this is the way that you have formulated in YAL protocol. The subsequent rate of adjustments also you can do according to the blood sugar level. This I'm not going to detail. Now coming to the protocol, how we are going to do. Yes, this is the IV insulin protocol for critically ill adult patients. The target range of glycemic control is 140 to 180. You have to bear it in 140 to 180, always have it in mind. The step 1, standard drip 100 units of insulin with 100 ml of normal saline, mix it. And then approved IV insulin is short-acting insulin of analogs. You got an aspart, you got a glulysin, you got a lispro injection, you got a fast-acting aspart also. All these things can be used in the IV preparation. And start IV line therapy when glucose is above the target level, and insulin infusions should be discontinued when patient has no history of diabetes and is receiving less than 1 unit. When you calculate 325 by 100, if you calculate it, and if the insulin level comes to less than 1 unit, stop insulin therapy. This is step 2. And step 3, bolus dose and initiation of insulin infusion. You can see, divide the initial glucose level by 100 as I told you before, and you get to the nearest value and start the therapy. And step 4 is the intravenous fluids that you have to give. Most patients will need 5 to 10% of glucose level infusion per hour, either dextrose solution or the dextrose with the off-normal saline. They can give 100 to 200 ml per hour, or equivalent to other TPN and other enteral feeding also can be added. Step 5 is adjusting the insulin infusion according to 2 algorithms. The first algorithm, we can start from the first algorithm, and if it's not able to achieve the targeted level of blood sugar of 140 to 180, switch over to algorithm number 2. And this is the algorithm number 1 and 2. They are given in the tabulation. You can see the blood sugar of almost 70 to 108. You have to give 0.2 units. You can take a picture only because we cannot go into detail of it. So you have to mug up, or you have to see, you have to keep it in your table and assess. So we cannot by heart these values totally. No. Then, according to the algorithm, start with the algorithm and go about it with the units per hour. Infuse the infusion as per that thing. And you are not able to achieve, go to the second algorithm pattern where the insulin levels are increased from the first level. And after that, what you are going to do, you have to monitor the patients. That is step 7. So hourly venous determination until the glucose levels are less than 440. Hourly, you have to monitor the patient hourly. And then capillary glucose every 1 hour until the glucose is within goal for next 4 hours. And then every 2 hours for the next 4 hours. So you have to by heart, or you have to take a snap only. Then, if stable, decreasing monitoring to every 4 hours. So hourly monitoring indicated for critically ill patients, even if the glucose is stable. And if the patients are hypotensive, the patient's blood pressure is less than 80 to 60, the capillary glucose values may be inaccurate. So in that case, patients with hypotension, definitely only the venous sample you can rely upon, not the capillary blood sugar level. And if any of the following occur, temporarily you can resume hourly glucose monitoring until the glucose is again stable. Okay, these are the things that can do. Any change in the insulin infusion rate, any sudden change in the infusion rate from it goes from 0.2 to 0.4 or 0.8, something, it just goes above, you have to think. Significant changes in the clinical condition of the patient, and starting or stopping the pressor or the steroids. The patients are already on steroid or pressor agents, and you are going to stop, then you have to change the modify the insulin dosage, and the starting and stopping of the starting or stopping the dialysis. The patients are under dialysis also, you have to think twice. And starting, stopping, or changing the rates of TPN and PPN are the tube feedings. So all these inputs that you are going to give it to the patient, apart from the IV fluids, that also counts in detecting the dose of the insulin therapy. Sorry. So coming to the transition, so the patients are chosen, convince the hyperglycemia you're going to manage for the patient, how you're going to detect the targeted level, and then you are giving the patients admitted in the ICU unit, you are going to start the insulin doses according to what I had told you. Okay, the patient is already comfortable, you are going to get back to the ward setting, how you are going to switch over from the IV insulin to the subcutaneous route. The choice of insulin in critical care is a transition by use. Establish the 24-hour insulin requirement by exploiting the average intravenous insulin dose required over the previous 6 to 8 hours. The previous 6 to 8 hours, the amount of insulin that he has taken, that you have to calculate. So take almost 60 to 80% of the total daily dose and give one half of as an intermediate acting or the long acting for basal coverage. Among this 60 to 80% what they have calculated from the 6 to 8 hours of insulin requirement, you have to take almost the one half of the dose should be given as a basal dose with a long acting or intermediate acting insulin, and give the other half as a bolus insulin, or the other should be divided into 3 portions and give other as a bolus dose before all the 3 meals. Hope you understood this. Easy. Previous 6 to 8 hours insulin requirement, calculate. In that you just can take 60 to 80% of the insulin requirement, and in that 50% you can give it as a basal dose, 50% as a prandial. Prandial you can divide into 3 components, divided by 3 first. So transition from IV to subcutaneous, a rapid onset of action of insulin allows the easy transition from intravenous to subcutaneous injections with minimal risk of hyperglycemia and without the discontinuation of intravenous insulin. And a properly planned transition requires that the first dose of subcutaneous insulin is administered at least 1 hour for short-acting subcutaneous insulin. Ideally, 2 to 3 hours for long-acting subcutaneous insulin prior to the discontinuation of the infusion. Then, the use of the ultra-fast-acting analogs such as FABs offers the practical and pragmatic advantage in this setting. Any short-acting, ultra-short-acting insulin, whether it's a Lispro or even Aspart also, you can use it. So, transition, the step 8 is the transition from IV insulin to subcutaneous. What's the basal analog method? Calculate the total daily dose for the subcutaneous insulin. The total daily dose is equal to infusion rate in hour into 20 hours. Infusion rate in hour into 20 hours. So, if the patient will begin eating, give him the half total daily dose as a basal dose, and the other half should be given as a bridging dose. And if the patient will continue the NPO, TPN and tube feeding, give all the total daily dose as a basal insulin and bridging dose as a 5% of basal insulin. So, this is what we can calculate from this. So, proceed to inpatient management of insulin in non-critical care setting. After this, what you are going to do, you can just proceed what the previous speakers has done in the non-critical care setting, you can proceed with this. So, remember, all patients receiving continuous insulin must receive a continuous source of glucose either via the 5% dextrose or TPN or the enteral feeds. And the insulin infusion to be discontinued if the patient has to leave the ICU for a diagnostic test as well as upon the discharge from the ICU. So, supplemental insulin, you can just give the extra amount of insulin if you want to have a better control when you do the CBG levels, the blood sugars are highly. Did not depend upon only the basal bolus therapy. You can give a supplemental insulin therapy also. And you can see hospital discharge transition. Patients with diabetes, start new insulin regimen prior to the discharge of the patient. Stabilize the blood glucose prior to discharge. Obtain the A1C level. Discharge planning, if the result not available for the previous 2 to 3 months time, you can take A1C levels also. And refer patient to a certified diabetes educator and provide specific instructions on medication use and provide instructions on glucose monitoring and teach them the hyperglycemia management also. Initiation of insulin at discharge can improve the own control also. So, the final summary, hyperglycemia in critical care. Numerous studies have demonstrated increased morbidity and mortality in critical care in critically ill patient with hyperglycemia. And the consensus recommendations suggest a target blood glucose of 140 to 180 mg per deciliter appropriate for the critically ill patients. And IV insulin aspart was found to be safe and effectively reduce the blood glucose level in critically ill patients. So, with that, probably you can thank you so much for the patient listening. Thank you.